STEMI, a journey of 3 decades. This session will be chaired by our former presidents, Dr. K. Venugopal, Dr. P.P. Mohanan, Dr. Chako K.A., Dr. M.N. Krishnan. Sir, please take the stage.
Hello. Good morning. I think we are going to listen to the most prestigious part of every Cardiology Society of India Kerala chapter meeting. That is the presidential address. Before Dr. Jayagopal starts his address, it is customary that we introduce him formally. Dr. Jayagopal Padil Balagopalan, MDDM, DPNB, FACC, FICC, FCSI, FAC, FCI, FRCP. Is a director and head of the department and senior interventional cardiologist, Lakshmi Hospital, Palakkad, Kerala. He was a former national president of the Indian College of Cardiology. He is the chair-elect of the American College of Cardiology, CARTI, that is Global Heart Attack Treatment Initiative. He is the associate editor of Journal of Indian College of Cardiology, member of the Heart Failure Council, Asian Heart Society, the principal investigator and national coordinator of Heart Failure Registry, Indian College of Cardiology, executive committee member of the Heart Failure Association of India, executive involved in the landmark trials, executive committee member of Society for Heart Failure and Transplantation. He has been involved in landmark trials like CREATE, Kerala ACS, ACS Quick and Heart Failure Quick, has 65 publications in peer-reviewed journals. He is the editor of Heart Failure Novel Therapeutics and Echo series books, and he has contributed more than 20 chapters in various books published. He is a former associate editor of Indian Heart Journal, and he has delivered 3 national orations. With this introduction, let me hand over the mic to Dr. P.P. Mohan for further comments.
I just want to add on that, since his topic also is STEMI. Now, his is the only center in India which is taking part in the GATI, the Global Heart Attack Program, which is essentially a quality improvement program in heart attack care. And I do expect him as the chair-elect of the GATI program, more elaborate findings, which has already given us some excellent inputs. The initial interim analysis showed that we could reduce the door to needle time. Very many things. This is mainly happening in the low and middle income countries. So the floor is to you, Jayagopal, for your presidential lecture.
Respected chairpersons, senior members, and dear friends. Now, at the outset, let me thank the CSA Kerala chapter for having given me this opportunity to be the president and also to be giving the oration today. So, when the stage producer, or the director, the script writer, Dr. Sajan asked me what I would like to talk on. In fact, my area of interest mostly has been heart failure. But this is an area where I thought STEMI is important, not just for one reason, because it's probably the commonest intervention that the cardiologist does. But also it calls not only for your skills, interventional skills, but also a bit of use of medical practice in your day-to-day journey. So, well, at the outset, let me tell Dr. Mohan that I am not allowed to share most of the data from GATI because for obvious reasons it belongs to so most of the things will be released soon. But then let me look back at what STEMI therapy is. When I graduated at a time when there is the 80s, there was absolutely no reperfusion therapy. The whole thing was a masterly inactivity, and where people were actually put to the end of the ward. The first intervention, in fact, I am thankful to Dr. Professor Rajan Manjuran, sir, he's sitting here, was IV metoprolol and acute myocardial infarction. Every patient with a MI, whether it was an anterior or inferior, was given a 3 doses of metoprolol IV, and then we meticulously. Well, this indeed reduced the arrhythmia. There was no reperfusion then. Subsequently, the ISIS-2 and the GIZI trial with streptokinase and aspirin showed there was a 23% reduction in mortality. And my chance of using the first Lytic was in an assistant professor in Kottayam in 1989. And then that really was, he was a young guy and had remarkable benefit from that. And the confidence too, after my stint in Jayadeva, where, at least about 10 to 20 MIs were lysed every day. But I think I would say the big day was, we were all interested, enamored by the cath lab, and then the state-of-the-art cath lab was actually introduced in Jayadeva. All the stalwarts, you can talk about big guys in India, they came in. First angioplasty was a patient of mine who brought a patient, his daughter, for AST surgery. He had a juicy-looking LAD. So Dr. MS performed the first POBA. There was no stents then. 8F guide, and then heparin, warfarin, no dual antiplatelets. We were the J and the A. J is for myself, A for Ali. clamp in action in the CCU. But 11 p.m., this guy developed chest pain, acute MI, and we were informed to call the surgeon. Nothing else could be done. Had an emergency cabbage. And then the only problem was his wound was never healed. He went on showing his heart. That was the Hanuman syndrome. So I decided that I will not take up this thing. But then subsequently was the learning curve, surgeons, we were only doing an angio, giving it to the surgeons. And I'm really indebted to two of my people. I will be failing my duty if I don't mention about Professor Chandrasekhar Rao, who really inducted me into cardiology. Dr. Thomas Alexander, a very good friend of mine, with whom I worked for about 11 years. And they actually shaped my career. And then finally, I got an opportunity to do the case's first exposure to radial interventions in the Europe PCR 2002. Well, the thing was, the 2005, initially we were using a Asahi catheter. I became an expert in twisting the catheters. And there was no way, and became an expert in taking it out also. But when the Terumo catheter came in, it was a game changer. Average PCA volumes, but then the ACS boom took place. Going in and out of Coimbatore became difficult. I ventured into my lab, and PAMI, the need of the hour, was established in 2008. So I think the important thing which pushed me into what I am today is basically the first testing on CREATE registry. Really indebted to Dr. Mohan for taking the initiative. We all know about the ACS registry, the ACS quality control programs, and of course, we were all part of the PARC registry, which Dr. Jabir introduced, with the radials were 2/3 by then. But then the mortality at that point of time was about 4.2%. And then because of all this, I tell you, this is one of the reasons why I got into the global heart attack team. I was in the working group, and I'm going to take over as a chair next year for another 2 years. So the main initiative is to improve the quality of care. This is actually done in about 22 countries. We have more than 55 centers are there. And as of now, we have more than 15,000 patients 10,000 patients who are enrolled in this. And we'll probably be coming out with a late-breaking trial in this ACC 2025. So I'm not really allowed to share all this data at this point of time. But I wanted to look at my own data. This is my own data, for example, on 1,234 patients in the last 3 years. We had 37 mortality. In fact, we are doing fairly well. This is all real life. They all properly documented. 2.99% is the mortality. And then the mean balloon to door to balloon time was 77 minutes. I think this is really wonderful. And I just wanted to share some of my learnings, which and the strategies that I adopted. I'm sure most of you know things here, but maybe just trying to reiterate the facts. It's the most rewarding for the patient as well as the operator, because you're saving a life there. And this thing has been a radial default, targeted examination. I don't want to go into the details. A screening echo, because VSR, all this can really ruin you. Anterior wall and cardiogenic shock. Yesterday there was a talk. I would actually, my threshold for intubating these patients is very low. I'd always put in a neckline, start them on inotropes and take it. But in the context where there is a florid LVF, I would wait, give a tenecteplase IV, and then probably take up. And in recurrent VT, when we have what Professor Manjuran taught me, IV metoprolol, it works wonders rather than pushing your metoprolol and Cardaron. Just wanted to share one of the cases, infraposterior MI. My colleague took it up, PAMI, balloon. But then what was really missed out was this patient was in hypotension. Nobody expects hypotension with such a lesion. In fact, when you saw next day, immediately after this patient was in tamponade, and you can really see the rupture there. And this is something which we cannot afford to. I think so. A targeted examination and a screening echo is mandatory. Most of our patients has been radial, but then femoral once in a while. And this is one of the cases where I took a radial catheter from the femoral. None of the 9 catheters would sit in place, and to take a long stent was not really difficult in this patient. Another thing of advice which I tend to do when you have a very big loop in the radials, is always to stabilize your guide with another wire in the circumflex. Of course, we do it when you have it in the circumflex. And one of the small things that I've been following is to use longer balloons. You heard about Oxford materials now. You have all these 10 balloons. In fact, I tend to use a lot of 2mm balloons, and these 2mm comes in 22, 26. Sometimes you do not know the distal end. This is an important thing. And one important strategy that which I have changed. Initially, we were all doing the non-infarct related angiograms. This is a guy who came with an extensive anterior wall. You could see a proximal LAD. This guy arrested. He had about 15 shocks asystole. And then the point is you have to get them out quickly, avoid post-dilatation. And in fact, this RCA shot was only taken later. Today, the 2024 publication, you could see the culprit lesion before complete angiography. This has become a standard practice. So in an anterior wall, I have no doubt that I would take them straight with an EBU guide and then finish off the job. But I think where I really made progress is routine. In the large thrombus burden. We all know from the 2 trials, the taste and the tapas, that this is not useful. It's only recommended for a bailout situation as per the European guidelines. Proximal torsitory, proximal LAD, if you have a huge thrombus, you will put it back in the left main. Distal location may not be very effective. Causal calcification, small size, all these are really, really not good candidate for a thrombus aspiration. And today, in fact, this is one of the editorials. It is faith cannot replace evidence, for sure. I still tend to use it, provided the patient comes 24 hours late when there is no window for lysis. And that evidence also suggests that the distal embolization comes down and there is improves the ST regulation. But then something else which I've been really looking at, and this is one of the publications to back up what my theory has been, this hypothesis I've been working on for a long time, is that intracoronary thrombus, in fact, though limited to earlier to some studies in case series, it's generally reserved for situations where there is significant large thrombus or a no reflow despite the usual aspiration techniques. And that's been one of my phenomenal experience in this field of STEMI. I've done this in huge thrombus. Not only that, stent thrombus, I'll share a few cases with you as an adjunctive in primary angioplasty. So this is one of our first few patients. You see the left main, the distal left main, and the circ is absolutely not visible at all. And this is 3 hours duration. So the protocols that we had developed calculate the dosage based on the body weight of tenecteplase, and that is the agent which was mostly used. 1/5 of was given coronary, intracoronary. And then you do a check and you have the sheath there, you find that there's some improvement of flow. The rest has to be given IV. The reason is because these are people behave just like a systemic lysis. You need the amount of lysis in your circulation and then immediately follow them the heparin 500 units per hour and then take a check angio 4 hours later. And this is what this patient was. You don't need a stent, they really come out. It's not just one case. We had a series of cases, initial cases. Now I have done it on more than 100 or 200 patients. This is our initial listing report on the tenecteplase. In fact, they came in for a lot of criticism, review criticism. The only problem that we had was a lot of reperfusion arrhythmias on the table and even in the ICU, VT, VF. So you need to be meticulous and following them up. But sometimes the important thing is that in a ectatic vessel, you know that there is thrombus, it may not work, posterior MI. Again, after lysis, then you find that the lesion becomes a very simple thing for you to do a very simple angioplasty. So this is the way to go forward. And I think this works much better than a glycoprotein 2/3 inhibitor in the context of an acute MI. So this again, tenecteplase, 8 milligram, check angio. And then this is one of the patients during COVID. During COVID, we also found that there was a lot of thrombus, guy with an anterior wall, almost in florid pulmonary edema. And that was what the right was. You see the left, huge thrombus in the left main. There's absolutely no LAD. You can just see the ramus was fine. Now, if you try to do an aspiration, it may not work. It even come into the aorta. In fact, you look at the TAPA style, you find more of strokes. That's these kind of patients that you're talking about with thrombectomy catheters. Now, this patient went through the protocol. Right, 5 minutes later, you see the LAD opening up, and then you see the difference. There's still a slow flow. But then subsequently, 4 hours later, it's absolutely free, and this patient is doing well after 4 hours. He also had hyperhomocysteine in addition to make the matters worse. But it's just not a PAMI, but also in the context of stent thrombosis. For example, this is a guy 18 years after he had a angioplasty Chitra 2 vessel, came with an acute inferior wall. He infarcted in the hospital. You see what it was like. Multiple balloon dilatations. In a stent thrombus, you have to dilate. But in the huge thrombus, you can't do anything there. Well, this only thing is here, we give a double bolus inside. And then that is what it was. The thrombus was there, and subsequently you could see the entire thing clear up. And he lived for another 2 years and had a mortality related to non-cardiac CAS. This is one situation where, the guy I was away from town. Somebody was covering, had an inferior wall MI, RCA, 4 stents all the way from the proximal to the distal. On tirofiban, on Brilinta, this guy had a stent thrombosis. What to do? This is a phone call I get. I said, there's nothing else to do but to lyse. So this patient was again given this thing. After multiple dilatations, absolutely no improvement in flow. Nothing could work. And this is where, the tenecteplase was administered. And this patient had, within no time, this had absolutely fantastic results. And I must tell you, this guy now went to Shabarimal and came back. He is absolutely, the RC is looking clean. So, not just PAMI, stent thrombosis, but also my concept is that this could even be in the context of as an adjunctive therapy. Well, there is something which is coming up. We all know the hypothesis is that it improves the microcirculation. There are studies which show that it reduces the gradient. Many agents have been tried, even streptokinase, 3 lakhs have been tried along with heparin. And then there are publications on this. In fact, this is why a patient had an inferior wall MI, long stent which was put in. You see, at the end of that, there is a slow flow. Because this was not adequate dilated because there was slow flow. And you find that it's so, but then you just give an adjunctive lytic there. And that's what you see there. Once you have an adjunctive therapy, it really works. The flow is excellent. So I think it's important to understand that even in the context, in fact, there have been studies in the anterior wall MI where they have been used. But I think the message is when you have slow flow, no flow, avoid multiple dilatations. Remember, it's timely reperfusion and not a cosmetic benefit. Avoid post-dilatation. intracoronary epinephrine, particularly in the context of somebody having a right RC occlusion, my threshold for starting adrenaline is very low, and it in fact does well. And there is of course the possibility that you could do a deferred stenting or a post dilatation later. But having said all this, the age is different. Today, I think we are going through an area where intravascular imaging is becoming very important. In fact, honestly, I tell you, I never thought that, because done thousands of angioplasties, and I really thought that if you do a good job, even an angiographic, this thing is very good. In fact, some of the operators like Bernard Muir was telling, he has never done imaging in his life. He was Grunsig's assistant. But then the point is, we know that these are useful, just like what we see in the other situation. You calculate the minimum luminal area to distal and proximal diameters, all these very useful. Post PCI, you can look at the MSA, the stent expansion, all these things are really very good, encouraging. But I just wanted to share one of the cases. This was actually 2 weeks ago. Guy came with an inferior wall infarcted 24 hours earlier, and then in pain. And the whole system was dependent on the right. And the right, you could see there was something like a very significant calcific distinction, which even with the 2 millimeter balloon, it just got opened up. The point is, at this point of time, you have to revascularize, basically dependent on the right coronary, and there's nothing that you could do. And then after dilatation, when you did the IVUS, you could see that this very tight lesion, and then most of the things were superficial. And then in this case, I used a Wolverine and broke the calcium. In fact, I had to go to real high atmospheres, even though in the context of MI. And then at the end of the procedure, that was what the vessel was looking like. The post run was very good. And then they really, really well opened. But I also must share you one of the things which I recently presented in the TCT also. The case scenario of 55-year-old guy, hypertension, chronic kidney disease, stage 3, acute chest pain, recurrent VT. He was so sick that, you had to really open up the vessel. In fact, the 3 millimeter vessel was just opened up right from the ostium, flared very well. And that was what it was looking like. And then he was doing well. But then 48 hours later, this guy had chest pain with ST elevation. And you see, it just got occluded right from the ostium. The challenge was, to get your guide in there to wire, because sometimes in the ostium it is very difficult to wire. Finally, it was wired, but unfortunately, this was an abdominal wire tracking. And then, though all the balloons went in easily, there was multiple dilatations with the 2, 3, and 3.8 millimeters. All this, despite all this, it was not opening up. The thrombus was persistent. At that point of time, the stent boost showed that this was abluminal. And in fact, then got another wire. I was able to manipulate one wire. And then after this dilatations, and now you can also see in the proximal part, probably the stent was not well open. But what really gave me an insight was actually the IVUS in this study. When you did the IVUS, we found that proximally you could see the stent deformity, and down below, you could also see there was a thrombus. And then what was even more perplexing, more confusing was the stent was really undersized. It was actually a 5 millimeter vessel, and we had only put in a 3 millimeter. So this actually, with the deformity, there was no second thoughts. You had to put another stent. So again, another stent was put in, and after that, this was blown up to about 5 millimeter, and then that gave excellent results, and we could come out with a MSA like this. You could see that this well expanded stent, no malapposition, and then in fact the final thing at the ostium was something like 10.4, 13.61. So I think these are things which tells us that today, if you have the option, I think it's good. I was just looking into the data. The first data which came in was a CAMI registry, where they did in a fairly large number of patients. One of the wonderful series. But they found that the IVUS guidance did not, compared to the non-IVUS guidance, did not have much difference in the TLR and TLF. But then the important thing was, if a patient has a younger age, prior MI, and one subset, left coronary, and a bifurcation, they did better. In fact, there is a recent publication now which shows that IVUS definitely has an importance, has an edge over the conventional angiographic guided. And so probably in the days to come, this will become a routine in acute myocardial infarction. But no, when you talk about ST elevation myocardial infarction, it's not just your opening of the vessel and your skill set, but also the real world use of medication. These are very important. So in fact, we did this prospective study on 1,200. Dr. Jabir was with me. We had 5 centers, even Jayadeva, another patient from Bangalore and Coimbatore. And we actually got it. This was presented in the ACC. What we found from the ICC days, the aspirin usage is increased. Clopidogrel usage was 77. Ticagrelor was 37. And mostly this was switched over on the second day. Beta blocker therapy and RAS inhibition has really improved over a period of time. And the mortality that we saw in this prospective study was only about 3.2%, which is what the contemporary data is. And the length of hospital day average was about 3.2 days. I think we are also seeing that along with this, we also must know that with PAMI, you also look at the unexpected. Today we have potent drugs like Ticagrelor. This was a guy who came with an anterior wall infarction. You see the left main was involved, the circ was involved, LED was occluded. wired. Finally, I just did a provisional stenting, took a long stent, 3.5 into 24, and then blew it up proximally, kissing balloon. Everything looked good. Then settled down. He had LV dysfunction. Everything was okay. But then, few hours later, in the middle of the night, I got a call saying that he's suddenly developed hypotension and bradycardia. And the medical officer immediately told me, short of atropine, he's back in sinuses. I said, you can't take a chance with the left main stent. Brought him back to the cath lab. In front of me, arrested asystole, put in a TPI, and then, but then to my, this thing was that the LED was flowing well. Of course, he had to be on an IABP. Now and then this was actually, he reverted to normal sinus rhythm. And the cause, if you would know, was ticagrelor. He's doing well after 6 years on clopidogrel. So ticagrelor and bradyarrhythmias, in fact, sinus brady pauses are known. Severe AV block, 7 cases reported, all needed discontinuation. So this is an adhesionous effect. If there is a pre-existing conduction defect, it's important to recognize this. But as I had mentioned, so use your drugs judiciously. This is another message in STEMI. Now, I think this is something which has just come out of the TCT, HELP PCI, where you pre-treat patients before they go into the cath lab with IV heparin, and they have much better open arteries before the procedure. So I think it's important, but then no significant difference was seen at the end of 30 days. Something new is coming up in the field of STEMI. That is what, again, the TCT, the Eureka first in human study procedure, where you don't need a vascular access. This is actually this device is in the pericardium, over the pericardium. There is an anchor balloon there. Over the anchor balloon, there is a wire there. Over novel anchoring, over that you keep a balloon, and then you try to compress, ECG synchronize. And this balloon will take something like 130 ml volume. And it will take 100, and this is what the system overview is like, and that really works well. And so to conclude, if you were to say 30 years of my journey, the question is, did you have more highs or lows? Well, looking back, I would say early transition into radial, that is, I started this program in 2005. I have had an extensive PAMI experience and journey, and that's been the most satisfying. I think the number of lives saved and the relieving support is really very good. And in fact, I had the opportunity of using the first ECMO in the country, 90 to 95% follow-up, which is the best learning. And thanks to all the research activities, I am involved in the STEMI quality program and involved in many of the CSA research activities. But unfortunately, the only guilt that I had mentioned earlier was I was never involved last year in any research activity, and that's really hurting me even today. I hope things will improve. And I would like to end by again bringing back the stage script, and also Dr. Sarjan here. All the world is a stage. Sarjan, I think the Jagadi Parnavali, all the stage, all the men and women are players. They have their exits. I am exiting now, and my entrance was over. And one man in his time plays many parts. Thank you, Sarjan, for the excellent opportunity. Thank you, the scientific chair. Thank you, the CSIK, for everything. Thank you.
Thank you, sir. I now request a check.
Yes, 1 minute. Those of us who have traveled in cardiology from the 70s to today have seen the explosion of knowledge in technology and scientific knowledge. Now, as expected, Dr. Jayagopal has taken us through this personal journey he had made in this subject. And he has done it wonderfully. We knew that he would do that, and he did it. Thank you very much.
Thank you, sir.
Thank you, sir. I request the chairpersons to please hand over a memento to our speaker. Thank you, everyone. Ladies and gentlemen, we have now reached the climax. Act 5, Scene 2. The cardiologist wants to know. I request the stage directors, Dr. K.P. Balakrishnan and Dr. Madhu Paulos, and the stage managers, Dr. Renju Kumar BC and Dr. Jittu Samrajan, to please take the stage. I would also like to invite our first protagonist of the session, Dr. Sarjan Narayanan, to please take the podium.
Good morning, all. So we have come to the final act of this Shakespearean drama, set in the beautiful picturesque scene of Alapi. Now we have come to we are at the scene 2. The cardiologist wants to know so many things. Yeah. A fool, Shakespeare once said, fool will behave like a wise man, but wise man knows he is a fool most of the times. So with those words, we go on to the first protagonist, Dr. Sajan Narayan, DCT versus regulating stand in ISR. Over to you.
Thank you for the introduction. Good afternoon to respected chairpersons and colleagues. I'll be talking about drug-coated balloon versus regulating stents in in-stent restenosis. And this is the plot which was given to me. Essentially, it is a very young person who had an acute inferior oscillation MI, came with a stent failure 4 years later, had a drug-coated balloon, again a device failure 4 months later, and what should be our considerations and what should be our discussions. Now, if you see what are the causes of device failure, it can be broadly classified into clinical, procedural, and scaffold-related factors. And some of these are eminently modifiable and some are not. Among these, the control of risk factors, especially diabetes and dyslipidemia, deserves special mention. If you see, this is a nationwide cohort study of Sweden over a period of 1 year. If you see the patients who had glycemic control, those patients who had very poor glycemic control as evidenced by glycosylation hemoglobin of more than 10%, their odds ratio of developing stent failure over a mean period of 6.4 years was about 1.35 when compared to patients who had a very good glycemic control. And the median HbA1c that separated patients who had good stent failure versus no stent failure was a glycosylation hemoglobin of 7%, meaning that if you achieve a good glycemic control, then you reduce the incidence of stent failure by an odds ratio of about 1.35. And this is Sanger Center data. If you see the control of lipidemia, if you have hyperlipidemia post-procedurally, then the incidence of stent failure is very high. So two eminently controllable risk factors, glycemic control and hyperlipidemia, which is controllable by diet and lifestyle modifications, and also good armamentarium, then you will reduce the incidence of stent failure or device failure. When we come to the procedural factors, this is a 46-year-old gentleman, acute inferior oscillation. I opened up the RCA. Distal reference was 3.25. Excellent. So we placed a 3 into 21 drug-coated stent. Excellent results. But when we took the post-procedure pullback, you compare with the pre-procedural vessel size, it has grown by about 1 millimeter. And those who are caring for patients with estilation MI, you should be mindful of the fact that there is a lot of sympathetic discharge. Vessel size can be underestimated, and you will choose undersized stents, and you will be leaving behind underexpanded stents, which can be nidus for stent failure. This is a 65-year-old lady post-PCOT RCA came with a stent thrombosis, and when we performed the intravascular ultrasound, distal reference was 9.3, proximal was 13.5, and the operator has left behind an underexpanded stent. MSA was 5.25, and the proximal edge, the angiogram was less impressive, but there was a significant lesion with a MLA of 3.95. So the operator has left behind an underexpanded stent and a residual disease, which are nidus for stent failure. This is a 42-year-old gentleman, acute inferior oscillation, diffuse lesion in the distal RCA. Excellent result of a stent placement, but with OCT, you can see there is significant degree of underexpansion and stent which is floating. So if you leave behind undersized stent, underexpanded lesions, underexpanded stents, and residual lesions, these are a very important nidus for stent failure. And if you see, these are the reasons for suboptimal outcome in the landmark IVAS ACR trial. If you leave behind suboptimal PCI, you don't derive any benefit on performing an imaging-guided intervention. So in this particular patient, what are the unresolved questions regarding the index procedure? Was the stent sizing appropriate? Whether this was any significant underexpansion that caused stent failure 4 years later. But now that this patient had a stent restenosis which was treated with a drug-coated balloon, now we should remember that drug-coated balloons are drug delivery devices. They are not meant for pre-dilatation. And the results of drug-coated balloon depends upon your aggressive lesion preparations. You can choose all the armamentarium from standard semi-compliant balloon to rotablation, and you should achieve these endpoints before application of drug-coated balloons. And if you see the host ISR depth registry, these are the standard 3 endpoints of good practice guidelines for use of drug-coated balloons. And if you don't achieve this, your TLR rates is about 67%. So drug-coated balloons has to be used on the background of aggressive lesion preparation. 58-year-old gentleman, acute inferior oscillation, late stent thrombosis. You open up the vessel, there was a diffuse instant restenosis extend to distal in-segment area. Distal reference was 9.47. There was significant new lesion that is developed in the distal outlet of the stent that was extending to the distal in-stent portion. 6.72 was the minimum luminal area, and proximal portion was free of disease. We aggressively prepared with a 3.5 scoring balloon. You can see that the MLA increased from 6.7 to 11.43. Excellent results. And so we applied with the paclitaxel coated balloon inside the stent and covered the distal in-segment area with a drug-coating stent, and that was the result. This is another person who came with a late stent failure. There was a diffuse lesion in the osteoproximal LAD and new lesion, the distal insegment lesion. So we prepared with a cutting balloon and demonstrated that a lesion has been improved with the cuts into the neoathuroma, and then applied drug-coated balloon in the proximal portion and drug-coated stent in the distal insegment area. That was the result. So the second procedure, whether there was any mechanical factors, whether imaging was used, because imaging is class 1 recommendation for in-stent restenosis PCI according to recent ESC guidelines, and whether an optimal angiographic results obtained before DCB applications. These questions are not answered. Now that patient has come back with the DCB failure, and it is described as a tubular lesion, which is according to ACCH nomenclature is 10 to 20 millimeter. What should be our management strategy? Whether we should go for repeat test or repeat DCB. Now, European Society of Cardiology guidelines is very clear that DES is recommended over drug-coated balloons, which is a significant change from the previous guidelines, which recommended drug-coated balloons on same choice as drug-eluting stents in the previous guidelines. American guidelines give only DES because drug-coated balloons are not available in American market. Now we'll delve into the caveats of these recommendations. If you see, go into the discussion of these guidelines committee, these are the two references that have been quoted by the guideline committee to arrive at such a recommendation. One is a Daedalus study and another is a meta-analysis. If you see the Daedalus study, this is a conglomeration of 10 studies. And if you see the year of publication, it is in the late 2000s and early 2015, when the first generation drug-coated balloons were used. There are no recommendations regarding the use of imaging, and the practice guidelines didn't mirror the current practice recommendations. And if you see the pre-specified analysis of Daedalus study, primary efficacy endpoint, target lesion revascularization, DES is better than drug-coated balloon for DES ISR. But when you see the safety endpoints, that if you use DES in DES, the incidence of composite of all-cause death, MI and target lesion thrombosis is higher, and it favors drug-coated balloon. So there is a trade-off in using a drug-coated stent inside the stent in a patient with stent failure. This is another meta-analysis that has been quoted by the drug guideline committee. Same drawbacks which I have mentioned in the previous applies to this. All the trials were in the early 2000s. So another single center study which has shown that if you have a focal ISR, that is defined as a lesion length of about 10 millimeter, drug-coated stents, drug-eluting stents is same as drug-coated balloons. But if you have a diffuse ISR, probably drug-eluting stents are better. So coming to our patient, if I will use a drug-coated balloon, if we can achieve a good mechanical results, if we get a very good results by aggressive lesion preparations, and this can be confirmed with intracoronary image. If I don't get an angiographic good results, I will go for repeat drug-eluting stent. So this patient I will manage with an aggressive lipid lowering, aggressive glycemic control, and if there is any left-sided disease, especially distal left main or proximally, I will have a very low threshold of recommending CBG, because natural selection, these patients have demonstrated that they don't respond well to stenting and they have drug resistance. And imaging must for third procedure, and repeat drug-coated balloon versus drug-eluting stent according to results which is achieved on the table. Thank you for the patient.
I think questions we are taking last, is it? Yeah, okay. So next one is anticoagulation versus intervention for excessive DVT. I invite Dr. Srital Rajan Nair.
Good afternoon, my dear teachers and colleagues. So the first thing, when Sergeant called me up and told me to present the topic, so the first thing which I did was to search the meaning of protagonist. So this is what it means. So we'll be having a discussion on anticoagulation versus intervention for DVT. So this was the plot which Sergeant has given me, and I asked how to present, so he told me as you like it. So this was a 35-year-old lady, hemodynamically stable, extensive DVT, echo normal, and started on LMWH and with a bridged warfarin and difficult bystanders. DVT, as we all know, is not a straightforward disease, it's a complex disease. And we'll just have a short discussion on the management of DVT before we go back into the plot later on. So DVT, as we all know, is not an uncommon disease, and it is very commonly seen in elderly, malignancy, and in the hospitalized patients. So, and the dreaded complication is pulmonary embolism. So we should all be aware of these things whenever we are dealing a patient of DVT, and we have to look into the patient deeply before we go ahead how to treat a case of DVT. So the treatment plan in a case of deep vein thrombosis is always based on the risk factor assessment, the extent and the location of the deep vein thrombosis, and the associated clinical conditions and other complicating factors. So, as we all know, in the West, most of the cases of deep vein thrombosis are managed on a home-based strategy, except for some conditions where we need in-hospital treatment, like an extensive DVT, a proximal DVT, patients with high bleeding risk, and other comorbid conditions. So only those patients are usually hospitalized and treated, but in the West, they have a very compact networking system where all this is possible. In our setting, it is not always possible. So how to approach a case of DVT? First is the risk factor assessment. We all know that we have to look for the provoked risk factors, the unprovoked risk factors, and we have to deeply see into the factors that have caused the DVT. For in this case, which we have is a transient risk factor. So recently the risk factor terminology have changed. They have classified it into transient risk factors and persistent risk factors. So some risk factors are transient, for which we need only limited duration anticoagulation. Some are persistent, for which we may need an extended anticoagulation or sometimes lifelong therapy as well. So the site of DVT is very important, proximal versus distal. Most of the distal DVTs are managed on a case-by-case basis. Most of them need only follow-up, but in some cases where there is risk factors for proximal extension, or if the patient has a malignancy sort of thing, they may need anticoagulation. So the distal DVTs are those below the popliteal veins, and in those cases, we have to select the patient on a case-by-case basis. Hemodynamic instability and other complicating factors drive the therapy and the right mode of treatment. Obviously, we know that hemodynamic instability, high bleeding risk, and limb-threatening DVT, we have to be more aggressive, and we cannot give all the usual standard therapy. Like if you have a high bleeding risk patient, you cannot directly go on with the anticoagulation. So we have to think before we start treating the patient. So limb-threatening DVT is a very important thing we should know. If there is a limb-threatening DVT, we have to try to be more aggressive in our treatment plan and move ahead accordingly. Associate conditions, age, advanced age, malignancy, as we already, and anatomic factors like the May-Turner syndrome need special consideration. So all these have to be evaluated whenever we are dealing with a case of DVT. So treatment options, we all know it is anticoagulation, and anticoagulation is the first choice treatment. Supported by, in some cases, we may need a thrombolysis prior to the anticoagulation, and in some cases, intervention is needed. So depending on each patient subset, the treatment may change. Interventions are not the primary mode of therapy in our part of the country, but then in some selected cases, recommendations have come that intervention should be adopted as the first line when there is no way that we can go ahead with an anticoagulation or an IV thrombolysis and the patient has a life-threatening condition. So the choices of anticoagulation, we all know it's always heparin, warfarin, and analogs, and the NOACs. So depending on each scenario, we have to select the best agent possible. Sometimes warfarin and heparin are the first line agents or the only agent that can be given in that scenario, like in a case of APLA in pregnancy or in a breastfeeding case. So in some cases, NOACs, in these sort of setups, the NOACs are contraindicated, so we cannot go ahead. But in the West, the recommendations have come that as far as possible, because they treat most of the cases on a home-based therapy, they are going for a NOAC-based therapy very recently, except for some conditions where the heparin and the warfarin are indicated. Again, the duration of treatment, we all know, we start with the medications, and then we have a primary treatment where for the transient risk factors, we go with 3 to 6 months of therapy, and after that, we can stop if needed. The risk factor is not there. or if it is there, or if the persistent risk factor, we have to go ahead with a secondary or extended anticoagulation protocol. So whenever you deal a case of DVT and we are planning anticoagulation, we have to look at the bleeding risk profile. There are certain factors which have to look at when you are dealing with the bleeding risk profile of bleeding risk of the patient. So all these are high risk for bleeding. So the number of risk factors, as the number of risk factors increase, the bleeding chance increases. So in such cases, we cannot go ahead with a anticoagulation or a thrombolysis. And in that case, we have to go ahead with another mode of treatment. So thrombolysis in DVT, whenever there is a low bleeding risk and associated major pulmonary embolism and limb-threatening DVT, always thrombolysis, either catheter-directed or systemic should be considered. And if when patients who are young, as in our case, they have high risk for a post-thrombotic syndrome, in the West, recommendations are there. They can give them the option for a interventional therapy, and if they opt for it, because that improves the quality of life, so you can go ahead with that. So catheter-based therapy always based for the enhanced, if you have an enhanced risk of thromboembolism, post-thrombotic syndrome, and limb-threatening DVT. These are the catheter-based interventions which are there. We have mechanical, aspirational, and rotational systems which are available. And sometimes if thrombolysis is contraindicated, you have to go for IVC placement. So the gist of the therapy is, the catheter-directed therapy is reserved for cases when there is a life-threatening condition and thrombolysis is contraindicated. So this was the clot registry, which shows that we effective clot removal with the system, and the chance of post-thrombotic syndrome is very less.
Sridhar,
Yeah.
please.
So last slide. So the 35-year-old lady, young lady, provoked transient risk factor postpartum, post-LSCS, subacute presentation, extensive DVT, post-LSCS, it's a contraindication for thrombolysis, breastfeeding, warfarin is the safe drug, normal cardiac function. So we have to rule out the anatomic factors. So in this case, I would like to go ahead with the LMWH with warfarin and give them the option of intervention therapy if they need a enhanced quality of life. Thank you.
Thank you, Sridhar, for the excellent presentation. Take up the key. We'll call upon Dr. Jayesh Bhaskaran as a protagonist role, Midcap versus PCI. The stage is yours, Dr. Jayesh.
Good afternoon. Thank you. Thank you, Sergeant, for the invitation. I'm here only because of Sergeant's convincing powers. So, he wanted me to sell CABG to cardiologists. So that's the crux of the talk, actually. So the case is an isolated LAD lesion with size mismatch in a patient with no contraindication for CABG. Now, isolated single vessel disease. So what is MIDCAB, or minimally invasive direct coronary artery bypass? It's a beating heart surgery done with either a mini sternotomy, partial lower sternotomy, or left anterior small thoracotomy. So the last was the original approach for MIDCAB, and later and more often now, people use the partial lower mini sternotomy. So it's been around. It's not a new approach. Actually, it's been around from the 1990s. Some of the German centers have done thousands of cases, and they have vast experience, large publications. And MIDCAB, the term has usually been restricted to single vessel, single graft using Lima to LAD. But surgeons have expanded their scope with newer technologies, robotic assisted or endoscope assisted harvesting. And now they are able to graft diagonal, RCA, and even some people have described circumflex grafting using the minimally invasive approach. And a variety of terms are in use. Mid-cap, of course, MICAS, minimally invasive coronary artery surgery, then total endoscopic coronary artery surgery, and robot-assisted coronary artery surgery. All these are there, and there is some overlap between mid-cap and MICAS, but usually mid-cap is restricted to single graft LAD using LIMA. So it's a small incision, as said earlier, and it's said to be less traumatic and lesser associated with lesser wound complications. So this is the typical field with the Chevalier retractor and small stabilizer and direct LIMA harvesting. So these are the two scars, the lateral thoracotomy scar and the partial lower sternotomy scar. But look at those, Sajan, they look uglier than the radial pinpoint prick. Okay, so even with these small scars, it's not easy to market to people. Now, what are the results of mid-cap? The in-hospital mortality in the most published series are less than 1% compared to 1.5% for op-cap and 3.6% for the older series of on-pump surgeries. And MACE-free survival at 2 years, this is from different series, survival at 2 years is 96%, and 5-year survival is 88%, and 10-year at 76%. These are actually comparable to the general population without coronary artery disease. So mid-cap offers, does mid-cap offer a survival advantage? Let's see in the next slide. And there is lesser surgical site infection because there is no large sternotomy involved and shorter ICU stay, hospital stay. But there is a significant learning curve. It's said that no surgeon should attempt mid-cap before at least 100 cases have been done on off-pump. And LIMA harvesting is challenging due to the smaller wound, and due to retraction, rib retraction, there is more surgical site pain during the first few days. So two recent meta-analyses have been published. The latest one in 2023. If you can see, it's very difficult to see but you can see that there is no direct comparison between mid-cap and PCI. No RCTs are there. They have taken some large published series comparison between off-pump CABGs and mid-cap, then PCI versus off-pump CABGs, and done the analysis. And this is the finding. So DES2 means second generation stent. So there is no significant difference in 30-day mortality, early MI, early revascularization, or stroke between the four groups. That is mid-cap, off-pump CABG, first generation DES, and second generation DES. And there is no difference in late mortality at 5 years, again between the four groups. In off-pump CABG, there is a survival advantage at 5 years. And mid-cap, the only positive for mid-cap is there is a lesser re-intervention rate for the target vessel and lesser MACE at 5 years compared to second generation DES. So that's only significant finding there. But the most important finding in this meta-analysis is off-pump CABG is superior to mid-cap at long term. Now we have different trials comparing CABG with PCI, BEST trial, NOBLE trial, and the EXCEL trial, which has been rejected by the surgery community because of something similar to cricket scores. Score. So this is another series of 566 patients, very low mortality and good survival. And this is a very recent study by Patel, direct comparison between second generation DES and mid-cap, and 9-year follow-up. There is no mortality difference, and re-intervention rate for the LAD vessel is significantly less for mid-cap. That is because PCI treats only one lesion, whereas a bypass graft treats the entire vessel. So new lesions in the same vessel might be causing the second MI. So factors that would favor re-intervention in the PCA group was longer stents, smaller stent diameter, older age of the patient, obesity. So these are the patients who might get benefit from mid-cap. Now, looking at the surgical guidelines, recommendations by the societies, no society recommendation includes mid-cap or hybrid revascularization. They have diplomatically avoided mentioning these. Actually. Again, even left main or LAD disease, stable ischemic heart disease, diabetics, OPCAP is preferred over PCI, but no mention of what is hybrid coronary revascularization. So you do at the same sitting or staged mid-cap with lima to LAD followed by PCI. If it's LAD is a culprit lesion, if non-LAD culprit lesion, you do the PCI first and then send the patient for surgery. So what will be the what should be the practice of role of mid-cap in our practice actually? So very complex osteal LAD or left main lesions, failed CTOs of LAD, recurrent ISR of LAD. These are straightforward cases for mid-cap. And those with uncontrolled diabetes and multiple comorbidities, of course, mid-cap might be preferable over CABG, regular CABG. Now, non-availability of lima due to previous surgery and cardiogenic shock, emergency CABG, these are contraindications for mid-cap because of the delay and difficulty in managing and difficulty in going on pump. And extreme obesity and redo surgery are relative contraindications. So are we going to send all our LAD lesions for mid-cap? Size mismatch is not an issue with the current array of stents which can expand from 2.75 up to 4.5 and 3.5 can go up to 6.5. So, and additional 0.5 mm Blackulum Goody means over and above the recommendation of the company. So this is one case which was referred for CABG. I snatched it from the surgeon's mouth actually and stented. So this is one case that should have gone for mid-cap, but definitely only cases like this which have no option of PCI in at least my practice, they go for surgery. This particular one actually, I tried my best. Even retrograde was difficult because of very small RCA and spasm in the RCA. So patient did underwent the mid-cap and he's doing well. This was done in Jan. So can you trust a surgeon to do mid-cap and not a full sternotomy? In all the large series, less than 5% of patients were converted to full sternotomy. But in our practice, what we see is there are some surgeons who take up patients for mid-cap and close to 40-50% of them get converted to full sternotomy. So this picture I won't, I kept just to keep interest. Thank you.
Thank you, sir, for the informative talk. I now request Dr. Mangalanathan P. sir to come on to the dais for his presentation on diet in cardiovascular disease, how to prescribe a sustainable heart-friendly diet. Meanwhile, Mangalan gets onto the stage. Actually, the watch has stopped ticking, okay? I think Jayesh has done some conspiracy with the people there. Please make sure that the clock is working, okay?
Good afternoon, everybody. Thank you, Sergeant, for giving me one of the most difficult talk. Because straightforward subjects are much easier to present here. So, dear friends, no, I am not transgressing into the next person's talk. This is Bethany Frankel. Your diet is a bank account. Good food choices are good investment. But I would like to say that food is a very hot topic. It's a very personal thing. It is highly related to your family, your religion, your belief, your area of living, your locality, your country. So there are so many things that affects your food choices. And no blanket recommendation can be given to a population as a whole. And this is the clinical scenario that has been given to me. A 42-year-old doctor is active, weight is decent, had a recent inferior myocardial infarction, which was treated with the primary PCA, and is enjoying good LV function. Prefer non-vegetarian dishes and egg. Love fruits but hates vegetables. He likes parotas, dosha, appam, those kind of things, and doesn't eat rice regularly. Chapati can be tolerated. Well, you all know the benefit of dietary advices in following or either as primary or secondary prevention. In fact, the nutshell of the recommendation that you are going to give any patient after myocardial infarction is in the following lines. And actually, it summarizes my talk. I can say that this is my final slide, which I am putting first. Eat more plant-based food. Of course, it's plant-based food and plant-based protein like tofu, chickpeas, lentils, peanut butter instead of the whole meat. Eat more fruits and vegetables, which are low in calories but high in fiber and vitamins and minerals. And the recommendation is to suggest, or people should try to eat 5 or more servings of fruits and vegetables per day. And eat healthier fats. Choose unsaturated oils like olive oil, nuts like almonds, walnuts, even our cashews and pine nuts. And limit unhealthy fats. Avoid trans fats and saturated fatty foods, of course fried foods. Limit added sugar, everybody knows. And of course, we should limit sodium, eat more fiber, eat lean protein like lean cuts of meat and fresh poultry instead of processed meats. And of course, eat fish which is high in omega-3 fatty acids. And the last 2 things, prepare at home. We do prepare most of our food at home. But now there is again a cultural transition happening as now the home delivery is happening more and more. And they prepare food in more healthier ways like steaming, roasting, broiling. And now you have air fryer like that. So I am not going to I know that all of you are going to have a lavish lunch. And what I do in my practice, I will tell. And I will say that most of us are charged for putting our patients after myocardial infarction into a great depression by offering them or suggesting them targets which they cannot meet. And every time they comes to you with a guilt, with these kind of things. So is there any way out of it? Can you take your patient into confidence and at the same time have your targets achieved as well? And I think I practice something similar. This is the way that my dietary counseling goes, whether in my OPD or in the wards before discharge. In fact, it's an ongoing process. It starts by the time the patient is in the coronary care unit. I start educating the relatives. Then while they are in the room with their family for 2 or 3 days. So these are the questions that we face. I think all of us face. And these are the answers which may look little surprising for you. Doctor, what is the diet control? And my immediate answer is, there is no diet control. So then they ask, sir, can he eat parotas as in our patients? Yes, I say, yes, he can eat parotas. Can he eat chicken? He can eat chicken. But there is a pause. Can he eat beef and mutton? Yes, he can eat meat and mutton. Can he eat fish? And he like it as fries. I am saying, yes, he can. But again, there is a clause. He won't eat any vegetables. Here, I will say, he should begin. Else. And he won't eat any salads. There again, I will say, he should start. Else. And he doesn't like many fruits. I will say he should identify the ones that he likes. So basically, we all go through these kind of situations, the questions, but the answers we may be giving will be slightly different. Why? Because a sergeant always used to, oh, my talk is over. Sorry. See, with the great power comes great responsibility. But I would like to remodify as per Nelson Mandela. The time has come to accept in our hearts and minds that with the freedom comes great responsibility. So with that, we'll come back to our clinical scenario. I am happy with the four things: his age, his active, his decent weight, and he has been treated well. But when it comes to non-vegetarian dishes, there is a catch. And egg is okay. So let us see these points, how I deal with. So here comes the food plate. I usually draw, I have a scribble pad in front of me, electronic. I can draw anything. I draw this, something similar. And my food is divided into 4 quarters. 1/4 carbohydrate, 1/4 salads and fruits, 1/4 cooked non-starchy vegetables, and 1/4 protein. This is the advice I give to every patient. And what is inside that 1/4 is subject to the patient's desire. He can have chicken, he can have mutton, he can have parotas, he can have, but I will recommend him that there is a healthier way, there are alternatives, but when you eat these things, the problem is not in eating this thing. The problem is that you are not following up it with the eating 50% of vegetables, half of which are fresh. That is the most important point that we should emphasize. By giving them the freedom to eat the things that they like, we should guarantee from that they also should eat the other part regularly so that their health part is okay. So this is the recommendation from the American Diabetes Association, the American government, even for the from our ICMR, we have an exhaustive dietary recommendation for every kind of scenario.
Mangalam,
And yes, sorry.
we should think about the mutton biryani as well.
Yeah, it's coming. Don't worry. So
No, time is ticking. That's
So we all know with the Mediterranean diet, and we have enough data of adhering to such a diet. And these are some scientific data of supporting it and some meta-analysis. And this is the food plate that I was talking about, the 1/4. And what about eggs? Eggs are an excellent food choices. They are low in saturated fatty acids and have some excellent nutritional things apart from choline. And when compared to other your food choices, egg and shrimp, they fare better than other food. And then this other scenario, your fruits, he has to eat. We have to compel him that if he want to eat meat and other things, he has to balance it with his vegetables. And I told you about the 5 portions of fruits and vegetables. This is the way to go. And parotas, can he have? Yes. look into this ICMR recommendation. When compared to our idli, sambar and other things, the parota, the glycemic index is much less. And Sajan, yesterday you gave only very small parotas, thinking to help improve our health. Just very small. So, in short, I will say that we should take a balanced diet, and our emphasis should be in promoting a balanced diet rather than blanketly blocking any particular kind of nutritional things. Thank you so much.
Thank you, Dr. Mangolan, for wonderful exhaustive talk. Now we come to the last topic. Very interesting, hot topic, I should say, and a very hot person to talk about it. Dr. Sujay Ranga will talk on sex after MI and heart failure, and he will take us from bench to bedside. Over to Sujay.
Good afternoon, stage directors and managers and seniors and colleagues. A few declarations and disclaimers before I venture into this topic. I have absolutely no idea why Sarjan chose me for this particular topic, but he said that I am the most apt person to talk on this. But then he assured that we will have an expert panel on stage, so who will also help me. Now, as soon as Sarjan published the brochure online, my WhatsApp inbox had a lot of requests. People wanted only pictures and videos. Some wanted live demonstration. One person also volunteered to be a model. And there was one person who stood out. He wanted a training village. And unlike all my previous speakers, I cannot post any pictures or videos. So all the photos that you will see are all AI generated. These are not actual photographs. But this is what happens when you bring up this discussion of sexual activity. Patients are frequently embarrassed to talk about it. But we must understand that sexual activity is an important part of the quality of life of the patient and their partner. And as treating clinicians, it is our duty to give scientific advice regarding sexual activity. But what we usually do is the cliche advice that if you're able to climb 2 flights of stairs briskly, then you can engage in sexual activity. But that is too much of a generalization for the cardiovascular demand of a sexual activity, especially in patients who are older and who have a cardiovascular disease. So if you look into the cardiovascular demands of a sexual activity, it is equivalent to a mild to moderate intensity physical exertion, equivalent to 3 to 6 metabolic equivalents depending upon the age of the person. So in older patients, maybe around 3 to 4, and younger patients, it may be around 5 to 6. There is an increase in heart rate, but not more than 130, an increase in blood pressure to up to 170 in normotensive people, but then it can vary. And the maximum increase is in the 10 to 15 seconds near orgasm, and there's a rapid decline immediately after that. It is same for males and females. So, in short, sexual activity is a simple exercise, but it requires mild to moderate intensity. When you deal with sexual activity in patients with cardiovascular disease, there are actually 2 issues. One, the cardiovascular risk of the sexual activity. Second is to manage the sexual dysfunction, which is very common in patients with cardiovascular disease. So if you look at the cardiovascular risk, people are afraid of angina. There is even a term called coital angina or angina de mort, it is called. It represents less than 5% of total angina causes. Second is the risk of myocardial infarction. The studies have shown that the risk can be around 1 to 3% depending upon the patient's age and physical capacity, but it is very rare. Autopsy studies have shown that in patients who have had sudden death, the risk of sudden death after a sexual activity is less than 1%. And in majority of cases, it happened in males, and 75% it's after it with an unfamiliar surrounding, with an unfamiliar partner after having a heavy meal and alcohol. So that is the one circumstance where there is a higher chance of having a sudden death after a sexual activity. And the risk of arrhythmias is also less. People with even with ICDs, they have a fear that they may have a shock during a sexual activity, and it can even injure their partner. But the chance for a shock during sexual activity, or even if the patient gets a shock,
the chance of injuring the partner is very less. So before you advise on sexual activity, we need to re-stratify the patients into either low risk, high risk, or unknown risk. Low risk would be any patient with a stable angina in CCF class 1 or 2, NYHA class 1 or 2 heart failure, people who are post myocardial infarction but totally asymptomatic, mild to moderate valvular heart disease, or any patient, anybody who is able to do an activity equivalent to 3 to 5 metabolic equivalents without any symptoms. High risk would be patients who have unstable angina, decompensated heart failure, severe symptomatic valvular heart disease, or uncontrolled arrhythmias. In these patients, we need to manage their cardiac condition before they can venture into sexual activity. And then there are unknown risk patients. Patients have heart disease, but we don't know their physical capacity. In such patients, we may need to do an exercise stress test before we can give them a go ahead. Now, what is the time frame for receiving sexual activity after a cardiac event? After myocardial infarction, 1 week or maybe a couple of weeks if the patient remains asymptomatic. After a PCA procedure, if the patient doesn't have any local site complications, even a few days after a PCA. After a cardiac surgery, 6 to 8 weeks if the sternal wound has completely healed. The second aspect is managing sexual dysfunction in a patient with cardiovascular disease. It is very common. And underlying causes may be different. Most commonly, it is the psychological aspects. The patient's fear, anxiety, and depression are the frequent causes of sexual dysfunction. The drugs that we give sometimes can contribute to erectile dysfunction. For example, if the patient is on a thiazide diuretics, it will be good to switch to a loop diuretics. Patient on spironolactone, you can switch to eplerenone. And if it is established that the patient's erectile dysfunction is secondary to beta blockers, you can consider stopping it if it is not absolutely necessary, or switching to nebivolol, which is more cardioselective and which is nitric oxide donor also. And few words about the pharmacotherapy, that is management of erectile dysfunction or sexual dysfunction in patients with cardiovascular disease. We have a lot of evidence with phosphodiesterase inhibitors, short-acting one sildenafil, long-acting tadalafil. They can produce some decrease in blood pressure. So you have to be cautious in patients with severe aortic stenosis and hypertrophic cardiomyopathy. Nitrate should never be given within 24 hours of giving sildenafil or 48 hours of giving tadalafil, because it can produce precipitous fall in blood pressure up to more than 50 millimeters of systolic blood pressure. And when you combine with non-selective alpha blockers like prazosin, again there is a chance of decrease in blood pressure. So you have to be careful if the patient is also taking alpha blockers, but it may not be an issue with more selective alpha blockers that we use for a BPH. And so in our patient is a young 45-year-old male who had a myocardial infarction post PCI. He was physically active. He's still now physically active, no symptoms. And according to the algorithm, if the patient comes into a low risk group, and he can safely engage in sexual activity. In people who are elderly or more than 55 years and who have symptomatic heart disease, you need to treat them before you can give them a go ahead. So the take home points is that sexual activity is an important part of the patient's and partner's quality of life. Those with stable symptoms and good functional capacity can engage in sexual activity without any cardiovascular disease. Those with unstable heart disease and severe symptoms should be managed prior to engaging sexual activity. Exercise testing can be done in patients in whom we are unsure about their physical capacity. And cardiovascular medication sometimes needs to be modified. Phosphodiesterase inhibitors can be given, but nitrate should not be co-administered. Anxiety, depression, fear should be managed. Patients with regular exercise actually have a low risk of cardiovascular events and sexual activity. So you must advise them to promote more physical activity. Females especially should be counseled regarding contraception and the risk of pregnancy. And sexual counseling should be given in all patients, which we unfortunately don't venture into. Thank you very much.
Thank you, Sujay, for that wonderful talk. Now we call upon all the protagonists.
I request Dr. Sajan Narayanan, Dr. Shrithal, Dr. Jayesh and Dr. Manglanandan to please join Dr. Sujay on the stage.
Yeah, regarding this first topic on DCB versus DES. Actually, your talk was well conveyed in one message that it is the biochemical control of all the risk factors that is much more important than the present treatment scenario. That does impress me actually, because controlling to the HbA1c as well as the LDL cholesterol to the targets is very important. We forget many times.
Yes, actually, if you see most of the data that is coming up, the glycemic control, if the person is, if there is another data that has come up recently that post PCI, if you follow up the patient for about 1 year, if they achieve good glycemic control at the end of 1 year, the incidence of stent failure is reduced by about 50%. So it is not enough that you achieve the glycemic control, it should be achieved as early as possible after the procedure to reduce the incidence of device failure. And also there is the importance of lipid lowering also. If you are going intense lipid statins or intense lipid lowering, it should be done as early as possible in the first 6 weeks, 8 weeks after the procedure to achieve great results.
My question is again to Dr. Sajan. This is regarding this. For instant resources, is it fair to conclude that for diffuse ISR, we need better go with a different type of drug-eluting stent, and for one which is not diffuse, go with DEB, and also whether laser helps?
Again, the first question, if I understand correctly, the question was that if you have a limus stent and that's failed, whether you should go for a paclitaxel coated balloon or
everolimus or something.
So most of the stents in the market now are limus. There is no Taxus coated stents are not available. So for initial, that's exactly why the paclitaxel coated balloon came into the market as the initial, because paclitaxel coated stents got withered away by the mid 2000s because the paclitaxel coated stents were shade inferior to sirolimus or limus coated stents. Having said that, the paclitaxel has some unique properties that makes it very unique for use in the drug-coated balloon scenario, because paclitaxel is a highly lipid-soluble drug and also it is a cytotoxic drug. So if you want a drug that will diffuse into the vessel wall within that 1 minute of balloon inflation, the limus group of drugs lack this quality. All those with the nanotechnology and some coating technologies, you can transfer the limus drugs into the vessel wall. But naturally, the Taxus group of drugs have that property. That is the exact reason why paclitaxel is the default drug of choice in patients who come with instant restenosis.
One question similar to this: when you had a sirolimus coated stent which had gone to ISR, will you be taking another limus for the next stent, or will you be going with the same sirolimus?
No, that also depends upon what is the etiology of a stent. That stresses the importance of imaging and other factors. It's not only the stent-related factors that is important. In a group of patients, in a given scenario, sometimes the patients may not respond to that drug. That is why I concluded my slide that if you have those patients who have a left-sided disease, because if you see that the profile of patients who come back with device failures, they don't respond very well to the vascular injury, and also they have some kind of genetic resistance to these drugs. So they have a different subpopulation of patients. So if this patient has a left-sided disease, if you have a proximally related disease or even a distal left main disease, I will have a very low threshold of recommending this patient for CBG, because historically this patient has proven that they don't react very well to the stents. So we should be mindful of the fact that a certain group of patients who come back with restenosis, they have a resistance to these drugs.
I will go to the next topic, anticoagulation versus intervention in extensive DVT. What is your recommendation about systemic thrombolysis in proximal DVT? Is it catheter-related thrombolysis or systemic thrombolysis? Which is better? Is there any role for proximal DVT?
For the proximal DVT, there is always a chance of pulmonary embolism. So the guidelines are not much telling about the thrombolysis. They say that there is a catheter-based thrombolysis which can be given for a proximal DVT and for a young patient, if like in our case, a young female patient, for the prevention of pulmonary embolism as well as for the prevention of post-thrombotic syndrome. Because for a proximal DVT, the chances of post-thrombotic syndrome is up to 30 to 40%. And what the interventionals also recommend is that if you go with the intervention, the chance of post-thrombotic syndrome is in single digits. So, but there is no ultimate guideline to say that you should be given a systemic thrombolysis for a proximal DVT. Still, in our setting, we go ahead with an anticoagulation protocol. So that's how it is.
Yeah, regarding this protein C, protein S resistant, deficiency, Do you have any data? Do we have any data? Because I have done at least 10 patients with DVT. Protein S was persistently lower in many of them, at least 80% of them. We should not be going with the European, but we do have these deficiencies.
If you have a documented thrombophilia syndrome, the extended anticoagulation is one which we should always consider. And those patients have a recurrent chance of DVT and possibly a thromboembolism. So in those cases, we should always consider for an extended anticoagulation protocol. Still, in our guidelines, there's first-line treatment if there are no other contraindications for the proximal DVT with the catheter-based intervention is not recommended as of now. But I don't know, the recommendations are just coming up. We have having data which says that the interventional treatment is giving good results when you compare with the anticoagulation alone treatment.
Just to add points, Dr. Sarjan mentioned about the paclitaxel sirolium. The TCT data showed the superiority of the paclitaxel drug-eluting balloon. But I beg to differ. The issue is the sirolium. There is a excipient property also that make diffusion to the vessel wall. Even at dish, it can go up to 80%. Now, Didalis study you are quoting, and there is a even it all depends on the TLR data. The TLR that segment, whether drug-coated balloon versus drug-eluting stent. Drug-eluting stent has a superiority and diffuse again. And second thing is role of biopsiable stent. There is future studies needed because it can dissolve, and especially proximal LAD, ISR. If you again put the stent and the high issues of restenosis again, so probably there may be even role. If you have a good, you have told already, there is, if you prepare adequately with rotablation and good luminal area, still we can think about the biopsiable stent in your future with the future studies. And there are studies not mentioned about that, the biopsiable stent. And second is regarding that protein C and S. Protein C, yes, if you have thrombophilia workup, don't look too much on the protein C. Many of the patients, they will the report will be in and around just elevated. Three things.
No.
I'm telling once again. Three things, that is factor V Leiden and antithrombin 3 deficiency and APLA. These three things are very notorious for the repeat embolism and all these things. And Dr. Sheetal mentioned the proximal part. 90% patient have post-thrombotic syndrome. Why? Because the thrombus accumulate. There is a valve, and valve, that hinge point, the thrombus were there. So just like our chordae of the mitral valve, that will block the thrombus, and that will retract the valve. So there will be always post-thrombotic syndrome 90% if it is femoral or until the poplite. So these patients, we had to be aggressive, like pharmacomechanical, rather than simply systemic thrombolysis. So there are radiologists available. We have to, other even interventional cardiologists also, we have to aggressively
Those
do
points are well taken.
Then additionally, and third thing is regarding any patient high bleeding risk, patient with thrombocytopenia and patient has DVT, always think about APLA syndrome, and you have to give unfractionated heparin rather than low molecular weight heparin, because the moment you give, for example, platelet count will be 30,000 or 25,000, and patient has extensive DVT, you can't give thrombolysis, then you have to give heparin. Many of the time, if the heparin increases the platelet count, that is the indirect sign is in APLA. And third thing I want to tell that even the last, you have been keep on telling your time is limited. The last topic by Sujay Ranga, you haven't asked to stop the topic because it is so interesting.
It was well in advance actually.
Okay.
He stopped well in advance.
Regarding
this protein C, I beg to differ there, because protein C and protein S are deficient in many cases. I don't know how many of we do that routinely, but I have done it in few cases and found it to be deficient.
See, Dr. Balakrishnan, in our experience, we have done it for a lot of patients. In fact, that was the thesis of one of our DM trainees. As Dr. Ashraf mentioned, many times protein C, protein S comes as borderline. Many times we find factor V Leiden, APLA. But significant change in protein C and protein S, I also have not observed.
I have seen that is why. Anyway.
Regarding the next talk, Dr. Jayesh, I wanted to know about you told about hybrid revascularization. Like you can go first with mid-cap followed by PTSP of the non-culprit vessels.
The order of revascularization, whether surgery or if you have a hybrid lab theater, you can do both at the same sitting. if you have culprit LAD, the first procedure should be the mid cap. And if you have non-LAD culprit, then that should be revascularized first.
So after how long you do the?
You can do at the same sitting if you have a hybrid lab.
Okay.
What about the anti-platelet strategy then? If you are stenting and doing the mid cap.
Mid-cap you can do with dual antiplatelets because there is only mini sternotomy or thoracotomy. And many people, what they do is they load with dual antiplatelets immediately after surgery.
Even the full CAPG they are doing with dual antiplatelets many times. Yeah, going to the fourth topic, diet and more interesting. Mangalan, you have done wonderfully well, but my question is focusing on a food as a therapy. How far we are scientific? Do we the consumed food, is it directly going to affect our health just like that, or is it the interior as well as exterior milieu which control the food and the behavior of the food, which the biochemistry of our internal milieu? Is that more important, or is the food which we are going to take?
You are asking something metaphorical question.
It's not metaphorical. My question is purely the genetics which we got.
Yeah.
One person is very lean, one person is very fit. He is taking very low calories, but we have enough number of anecdotal evidences in front of us, like very fit people having certain cardiac death first MI, isn't it?
Yes, that is of course that the genomics and your gut biomes. A lot of things come into play. Ultimately, what happens to your food and ultimately what will happen. But we have scientific evidence to say that there is atherogenic diet. There's no doubt. And but there again, see, if you take the whole meat, the problem is not with the meat, but the kind of meat that you are taking and the content of the saturated fatty acids and the ratio of saturated fatty acids to monounsaturated fatty acids and polyunsaturated fatty acids. The recommendation is that, for example, if you take egg or cashew, here the monounsaturated fats is very high. In fact, if you take cashew, of course, nuts, it's around 70% is monounsaturated fatty acids and 17 to 20% each of polyunsaturated and saturated fats. Just like the problem with the meat is that the content of saturated fatty acid is much high. That's a problem. So to counter that, to keep the balance, you have to eat other kind of protein or other substances which is having higher content of the healthy fatty acids. And of course, always remember 50% of your food has to come from vegetables. And vegetables again, we should tell clearly that the starchy vegetables are not the vegetables that the patient should take. That the tubers that is grow under the ground, that if the patient can take, but that the allowances has to be allocated into the 25% of carbohydrate. So patient can have rice, he can have kappa, but he cannot have it together. If he wants together, let us have little bit, 12.5 and 12.5% each. That message has to be clearly communicated to the patient. Patient can have anything provided they allocate it into this 25% quota each.
Would you educate a dietitian prescription as a therapy, mentioning the calories as well as the proteins and the
I do occasionally, but most of the time I counsel myself. But when there is some total failure or lack of cooperation, and 2 or 3 times you have explained the things to the patient, and I know that just like a stent failure or drug failure, I am a failure for that patient. At that situation, I will send the patient to because I don't want to spend more time with that particular patient.
Now the final topic, sex after MI, Sujay. I hope there will be more interaction from the floor this time. Yeah, you have done wonderfully well on that. No, but I would like to add a point on the point which you told about erectile dysfunction. Erectile dysfunction, what I feel as well as what the literature tells us is that it's because of the nitric oxide inside your body. So basically, it is the endothelial dysfunction which is producing the erectile dysfunction. So that must be the first manifestation of the whole disease process.
Vascular disease. Yes. It
Vascular
can
disease.
actually precede cardiovascular disease by up to 3 years. So it can be indicated that the patient is having a cardiovascular disease. So
Need not be
3
your
years,
drugs as well
yes.
as your depression and all.
yes,
It can precede actually.
it can precede the cardiovascular disease by as many as 3 years before you develop the cardiovascular disease.
Now the endocrinologist is saying that you should control your lipids better for better endothelial function to prevent erectile dysfunction. They are advocating aggressive dyslipidemia treatment which will benefit for erectile dysfunction also.
Quite naturally, because that is exactly the point. See, the vascular suppleness of your arterial system, that is what guides the erectile, whether you are potent enough or you are having an erectile dysfunction. So, all the risk factor management is actually the primary prevention for erectile dysfunction as well.
Basically, the 10-15 years there is a Medtronic trial, just a trial. And that trial I still remember because if you have a multivessel disease, you look at the Indian iliac artery and the pudendal artery. Many of the time there will be even up to 40-50%. I don't know, remote memory. You have to recheck it and you have to check for the stenosis. So you always exclude the vascular cause and you can even put the stent. So if at all you have this one and you asked any history of erectile dysfunction, and there is a vascular cause for that, and even people tried with the Endeavor stent. That was a ZEST trial those time. I don't know. So that interventional radiologists are doing all these, but as chairperson said, this is a vascular disease, and even that is new information. It is preceding the coronary. Okay, next time.
Actually, once one famous star from Hollywood said, once your sex life is active, your vascular system is active, you are going to have a better lifespan as well. Shall we take that point? What is your opinion on that? So with that consensus, I think, can we wind up this session, the final act, and we'll go to the renowned session. Over to
Thank you so much, sir, for a wonderful end to the meeting. Let's have the last bow and the photograph together. After this photograph, I would request all the delegates and faculty who are here to come forward, and we'll all take a snap together for good old memory's sake. And after that, I want the organizing team, audiovisual, Anish and team, Swami Chetan. And after that, I want my friends from the industry to come forward onto the stage.
Dr. Jayesh, actually I want to ask a lot of questions, but this will be a boomerang from you, so I thought not to ask any question.
Request all the delegates to come to the stage, please, for a group photograph.